Good evening, all the aspirants. Here we have the speaker, Dr. Asif Iqbal, who is a HOD Respiratory Care and ECMO Services at Apollo Multispeciality Hospital, Kolkata. And the topic for today is Respiratory Pneumonia ARDS ECMO CCS session. Thank you, sir. You may take over.
Thank you for kind introduction. For the student who will appear EDIC Part 2 exam, so you definitely get one cases where patient having the pneumonia, and they will ask about all about the ARDS management and the ECMO management. Yeah. So this is a very important class, and those who are missing it, please they should take the recording. Fatma, please ensure. Okay. So now
Sure, sir.
my screen is visible.
Yes, it is visible. Perfect.
Okay. Yeah. Thank you. So the first vignette in the CCS, you will get the cases in a venient manner, and for the long cases, you will get 5 to 6 variant, and in a short case, you will get 3 to 4 variant. Okay, so variant nothing is a scenario. First variant, after giving the first variant, they will give you a little bit time, and after that they will proceed the case. Okay. So first being a 60-year-old man presented emergency department complaining of persistent right-sided chest pain and cough associated with productive sputum, yellow in color, and little bit hemoptysis. He was admitted to general medical floor for the treatment of community acquired pneumonia, and he has initiated ceftriaxone, azithromycin, oxygen through nasal cannula, and other supportive measure. By hospital, day 3, his respiratory status continued to worsen and requiring transfer to intensive care unit for hypoxic respiratory failure. On arrival in the medical ICU, the patient appeared dyspneic and desaturated on the NRBM 100% oxygen. Patient was started NIV support but continued to deteriorate on the NIV. Maybe this is a clear-cut scenario. They are wanting to ask about the ARDS. Yeah. But most of the time you will get scenario like that is community acquired pneumonia kind of thing. The patient having fever. Usually they give the old age patient around 55 to 60 years, and then fever, cough, little respiratory distress, and they presented to you. So what will you do? So then the question will start from like whether this patient need intubation or not. Means they are asking about the CRAF score, CRAF 65. It's like that. So this is a case where the community acquired pneumonia admitted in the floor with ceftriaxone, azithromycin, and day 3 patient further deteriorate, shifted to ICU and the NRBM. So the question from this scenario, they might ask, what is the differential diagnosis of your patient? What is your immediate management of this patient? How will you intubate this patient? What is your initial ventilator strategy for this patient? What is your limitation current volume definition for the ARDS? This kind of question. So first thing, if the question is differential diagnosis, so you have to tell about the what are the differential diagnosis in CAP or in a pneumonia. So it is a bilateral pneumonia with ARDS, bacterial or viral, though you have not received the X-ray yet. So you have to tell about that this is you are dealing with the case of pneumonia because cough and fever is there. So maybe the pneumonia migrated to ARDS. It may be the etiology may be bacterial or viral. And also this patient can have the topical illness like dengue, malaria, Krabs typhus. A lot of dengue patient, Krabs typhus patient, malaria patient, they can develop pneumonia. Then there might be a connective tissue disorder, Wegener granulomatous disease, congestive heart failure, interstitial lung disease, AEILD, or AECOPD can be there. So in that case, now the EDIC has been changed, the pattern, marking pattern has been changed. Initially, it was like that 5-pointer, 3-pointer, 2-pointer, 1-pointer. So if you give the correct answer, means what is they are expecting, you will get the 5 point. And nowadays is not like that. It's the all answer is the correct answer is the 1-pointer. So you have to be very precise and you have to give the all the data you have. Like in the diagnosis, you can say only it may be the community acquired pneumonia progress to ARDS or congestive heart failure, but you can wait. But no, the tricks is that you have to utter all the possible cause. So you might, you never know if you give only two answer and if this is two answer is correct, only you will get 2 marks. If you give the 10 answer, might be 5 answer is right and 5 answer is wrong. So remember in EDIC, there is no negative marking. Even if a practical exam is not like our Indian system that if you give wrong answer, it will have wrong impression. Yes, if you give very wrong answer, then it will create a wrong impression. But you have to give all the possible causes, which may be the etiology, okay, for the respiratory distress. Then the next question was in the variant. Next question was, what is your immediate management for this patient? So immediate management in this scenario, the patient is, if you see that patient on the NIV, in the NRBM 100% oxygen patient was started NIV support, but continuously deteriorate on the NIV. That means the indication is in the NIV failure. So you do not wait or you do not utter the HFNC, I will give the HFNC, I will wait for the NIV to settle down of the patient. No, you clear cut say you have to say that I will go for the mechanical intubation. So from the mechanical intubation, they might ask you question about how will you optimize your patient, what is the physiological difficult airway, what is the how you think that the intubation was easy or not. So remember the difficult airway is in the ICU, all the patient are under the category of the difficult airway because they are anatomic. There might be anatomical difficult airway or the physiological difficult airway. What is the physiological difficult airway? They might be on the inotropic support, they might be on the hypovolemic status. So when you are intubating, you are giving the sedation drug, there might be develop hypotension and cardiac arrest can be precipitated. So you need to optimize the patient. You need to optimize the volume status. You have to use this agent which causing very less a hemodynamic instability, like you can use etomidate as an induction agent. You can use remifentanil. And regarding the muscle relaxant, you use the rocuronium because you have a sugammadex for reversal agent. And then you are putting the mechanical ventilation. They might ask about the what will be your ventilator setting. So you have to ask about the ventilators. You have to have the answer of the ventilator setting, like the fourth question, that what is your initial ventilator strategy for this patient? So lung protective ventilation, moderate, high PEEP, open lung ventilation. I will use tidal volume as I will set tidal volume as per the predictive body weight. They might ask question about the predictive body weight. What do you mean by the predictive body weight? How you will calculate the predictive body weight? Then they might ask about your PEEP strategy. How will you set PEEP? What do you mean by the open lung ventilation? They might ask about the trial name. What trial support your open lung ventilation? So you have to utter this ARMA trial name. You have to know the recent development on this field. Okay. Then the question is, what is the limitation of the current Berlin definition? They might ask about the Berlin definition and the limitation. So current, the recent American College of Chest Physician, they have recently given the criteria of new diagnosis of ARDS, where in place of PO2 FiO2, they are using PO2 SPO2. SPO to FiO2 ratio, because there are lot of resource limited center where the ABG is not available in a third world country. Even in India, in the district level hospital, they don't have the ABG facility. So PO2, FiO2, you can't measure. But SPO2, every nursing home, every small setup, every hospital, they have the SPO2 facility. So that's why now the new amendment is the SPO2 FiO2 ratio. In the they have included in the definition.